مرحبا. اليوم موضوعنا عن البون augmentation. In oral and maxillofacial surgery we talk about الautogenous and non-autogenous PRF and PRP. هذا الموضوع راح نقدمه أني داليا مثنى وزميلتي داليا محمد. Introduction. What is bone augmentation or bone grafting? It is term used to describe a variety of procedure used to build bone so that a dental implant can be placed. This procedure typically involves grafting bone or bone-like material to the jaw. The graft can be your own bone or be processed bone. After grafting, you have to wait several months for the graft material to fuse with the existing bone. The indications for bone graft, which is 3. Number 1, filling of acquired bone defect, such as following the tumor extirpation or continuity defect following the trauma. Number 2, surface augmentation, such as replacement of bone graft for zygomatic origin augmentation. Number 3, reconstruction of congenital defects, such as bone grafting for alveolar cleft defect. In this picture, we show a mandibular reconstruction with a primary placement of osseointegrated implant. The properties of an ideal bone graft material, which is non-toxic, non-antigenic, resistant to infection, predictability, clinical visibility, easy adaptability, readily and sufficiently available, minimal operative and post-operative hazard, adequate bone fill, and promotion of a new attachment include cementogenesis, cost-effective and acceptable to the patient. Mechanism of bone regeneration and augmentation, which is 3, osteogenesis, osteoinduction, and osteoconduction. What is osteogenesis? It is the synthesis of a new bone by donor cell derived from either a host or a graft donor. Cells involved in this process include the MSC cells, the osteoblast, and the osteocytes. The osteoconduction. It is used to describe bone formation from either adjacent bone or periosteum via the ingrowth of capillaries and osteoprogenitor cell from the recipient bed into around and through the bone grafting or bioimplant. The graft or bioimplant act as a scaffold for new bone formation. Unlike osteoinduction, this process occurs in an environment already containing bone. Osteoinduction. Osteoinduction, it is a process when undifferentiated pluripotent cells are stimulated to transform into bone-producing cells through the release of active factor and thereby form bone in an area previously devoid of it. PMP is the most studied and the most prolific bone-inducing agent, occurring naturally during the genesis of bone or following the fracture repair or by exogenous stimulation. Autogenous bone graft, which is involved the harvesting of bone obtained from the same individual and collected either as a bone block or as a particulate form. In this picture, we show autogenous bone graft as collected as a bone block, and in this picture, we show autogenous bone graft collected as in a particulate form. Autogenous bone graft is favored over other non-autogenous bone graft because it is osteogenic, osteoconductive. It can act as a scaffold to support the ingrowth of a new tissue and cell, and osteoinductive. It can induce stem cell into osteoblastic pathway. Donor site. Intraoral donor site which is either intraoral or extraoral. Intraoral, which include number 1 in mandibular ascending ramus, which is the third molar area as seen in this picture. Number 2 in mandibular symphysis as in this picture. Number 3 in maxillary tuberosity. Extraoral donor site. The main extraoral donor site include iliac crest as seen in this picture. Number 2 proximal tibia. Number 3 cranium. Advantages of extraoral site is that a large amount of bone can be harvested for reconstruction of large defect. Disadvantage of all extraoral site is the need for a surgical site in addition to the intraoral site, and the possibility of post-operative morbidity associated with the bone with the donor site. Various commonly available autogenous bone collectors. In this picture we show a bone scraper, and in this picture we show a suction trap, and this is which is an implant drill. This is a trifine burr, and this is a rotary burr harvester, and this is collecting burr. Now we talk about the procedure or technique of autogenous bone graft. In these pictures, we show a preoperative clinical image demonstrate loss of the right central incisor, resulting in a loss of ridge width. And in this picture, we take a preoperative CBCT image. This picture show following flap elevation, not the compromised alveolar ridge. In this picture, we show the use of piezosurgery device and the bone spreader, which is used to take the bone block in the area of mandibular ramus. And this picture show bone block after removal from the donor site. In this picture, we show recipient site preparation, include intramarrow penetration, and in this picture we show illustration of step for autogenous block grafting. In this picture we show marrow and cortical surface of harvested block graft. In this picture we show block graft fixation. In this picture we show particular graft mortising. In this picture we show collagen membrane placement with fixation. In this picture we show use of PRF membrane over collagen membrane to facilitate soft tissue wound healing. In this picture we show soft tissue closure at the donor site, then soft tissue closure at the recipient site. Then we put provisional restoration. We wait 4 months to show the result, and so in this picture we show 4 months post-operative and show an increase in the ridge width. And this CBCT image after 4 months أيضا show an increase in the ridge width.
Assalamu alaikum. I'm Dalia Muhammad. I'm going to continue the presentation about bone augmentation, and I will talk about non-autogenous bone graft. Non-autogenous bone graft or alloplast are synthetic biocompatible option for implant clinician. Alloplasts have the advantages of no immunogenic response and no risk of disease transmission. because of the possibility of disease transmission from allograft and xenograft. There has recently been an increased demand for other bone substitute options. Types of alloblast: hydroxyapatite, bioactive classes, tricalcium phosphate. This is a surgical procedure of alloblast. This procedure is distal extension sinus grafting utilizing a crystal approach on OD bear. From A to E, use of OD bears for osteotomy preparation and implant placement. This is OD bear. From F to H and alloblast putty, nova bone is utilized to add bone volume to the apical portion of the osteotomy. Nova bone is a unidose syringe delivery method, allows the clinician to clearly see how much bone graft is being used. It's 100% synthetic and resorbable calcium phosphosilicate dental body. Osteostimulator effect of material result in stimulation of osteoblast proliferation. I and J OD bear are utilized to propel the bone putty apically. K implant placement. L soft tissue closure. M clinical view 3 months post operative. N and O clinical view at 3 years. P and Q CBCT demonstrating maintenance of adequate buccal bone volume. The growth factor utilized in dentistry are divided into 2 main categories: PRF and PRP. PRF, platelet-rich fibrin, is an autogenous material that is derived from person's own platelets and is used to enhance wound healing and tissue regeneration. Clinically, PRF is easily produced by chairside from the patient's own blood. PRP, it's a platelet-rich plasma, is a technological procedure which involves the formulation and the use of the patient's own blood plasma. The PRP is therefore 100% biocompatible and safe to use in dental implant surgery. PRF preparation: extract blood, use PRF centrifuge, PRF tube after separation, use PRF box, take PRF part, and finally use of PRF for dental treatment. Process of PRP therapy preparation: collect blood, separation of platelets by using centrifuge, extract platelet-rich plasma. This is a procedure. Use of LPRF as a butter membrane with mineralized allograft for routine socket grafting. From A to C, clinical presentation of maxillary canine and first premolar requiring extraction. D to F, CBCT image of full arch on the maxillary left canine and first premolar. G and H, minimal traumatic tooth extraction performed by using power tome. I, occlusal view following tooth extraction. J and K clinical images demonstrate the lack of buccal bone and the presence of a thin biotype. L. Preparation of LPRF membranes. M. FDBA mineral oils mixed with LPRF exudate. المينرال اوس or ال FDBA هو عبارة عن freeze dried bone allograft combines freeze dried cortical and cancellous bone. This combination provides the variety of characteristics required to enable high quality new vital bone formation. N. LPRF membrane tucked into the buccal bush. O and P FDBA is placed with a moderate concentration within the extraction socket. Q. Occlusal view of the grafted site. R. Intact LPRF membrane. S. Final sutures. T and U. Suture removal at 2 weeks. Notes: the excellent soft tissue healing. V and W labial and occlusal views at 4 months. X and Y radiographs of both sides demonstrate adequate mineralized tissue and grafted sites. Sinus lift procedure. Sinus augmentation procedure are routinely classified into either lateral wall or crystal approaches. Surgery may be performed using either a 2-stage or single-stage protocol. This procedure is a lateral sinus augmentation utilizing a single-stage protocol. A to C incision design. Same as 2-stage technique for distal extension edentulous spine. D to F outline and removal of bony window with a number 8 round burr and a piezo surgery device. G. Membrane elevation with a piezo surgery elevator. H. Membrane fixation and graft placement composed of mineralized allograft, mineral os, xenograft, bio-os, and LPRF membrane. I. Implant placement into the grafted area. J and K. Final graft placement up to bony window. L and M. Placement of rigid collagen membrane. Memlock externally to cover the window, followed by application of LPRF membrane to facilitate soft tissue healing. N. Soft tissue closure. Thank you.